Good morning or afternoon, as the case may be, and welcome to today's webinar on our 2021 calendar, part 3 of our 3-part Sexually Speaking, Brain Injury, Development, and Behavior series offered by the National Association of State Head Injury Administrators. I'm Maria Crowley with NASHIA, your moderator, and Haley Cushion is with us as well, NASHIA's Coordinator for Member Services and Communications, as our organizer today. So thank you so much for joining us. NASHIA is a nonprofit organization created to assist state government in promoting partnerships and building systems to meet the needs of individuals with brain injury and their families. Once again, we're using the GoToWebinar platform for this event today. They provide online support should you experience issues. Handouts of today's presentation is available for download. Check your attendee control panel pane for the handouts pane. Please submit your questions in the questions pane on your control panel, and we will forward those to our speaker if we run out of time at the end of today. Otherwise, we'll try to answer those at the end of the session. Continuing education credits for social work, certified rehabilitation counseling, and a general certificate of attendance. Those are all available for today's event. At the end of the live webinar, you'll receive an email with an evaluation. The CEs are bundled for this series, as I have mentioned to you before. In order to receive credit, you'll need to listen and complete the evaluation for all 3 sessions in the series. The webinar will also be archived for later access on our website under Trainings on Demand. For viewers of the recorded version, please go there and find information on how to obtain your certificate. Okay, I would now love to introduce you to today's session and also to our presenter. Problematic sexual behavior for individuals with a brain injury at home or in the community can be a barrier to independence, school, and work, as we've discussed during our series. Today's session is going to focus on resources for you related to building intimacy, capacity to relate to others, and a focus on addressing sexual function with adults with disabilities across the continuum of care. Inpatient and outpatient approaches, both will be presented. This is Kyla Browning. I would love to introduce her to you. She's an occupational therapist with Sinai Hospital in Baltimore. She spent 2 years working in acute care at Johns Hopkins and has spent the last decade at Sinai in Baltimore working on inpatient neurological rehab unit. Her specialty is focused in this area on addressing sexual function with adults with disabilities across the continuum of care at Sinai Rehabilitation Center. That includes acute care, inpatient, and outpatient supports. When Kyla's not working, she enjoys spending time with her family, riding on her Peloton, me too, boating during the summer, traveling and reading. So Kyla, welcome. We're so glad you joined us today.
Thank you. Okay, first off, I just wanted to thank you all for your patience with me in this presentation. I hope you all enjoyed both previous presentations. I've learned so much myself from watching them, especially rephrasing the vulnerable population to uninformed population. I definitely need to start using that one myself too. So here are our objectives for today. First off, we want to identify the personal barriers that may affect addressing intimacy and sexual function. We want to make sure that we're describing the different models for addressing sexual function and intimacy, describing the role of the therapy team in addressing these issues, especially with our brain injury population and their caregivers. We want to address issues that arise after brain injury in developing and maintaining social and sexual relationships. And we want to make sure that we're discussing strategies on educating our caregivers, partners, spouses in supporting these positive relationships as well. A little bit of background on Sinai and myself. Sinai Hospital of Baltimore is a 483-bed hospital that has acute care, 2 inpatient rehabilitation units, 1 general orthopedic rehab unit, and we have our 20-bed neurological rehabilitation unit. It also has a locked side on this unit for our brain injury population. We have what's called our Restore program on this unit, which is specifically for our brain injured patients. We only accept Rancho levels 4 and above. Sinai also has outpatient services, which include our mild brain injury program, as well as our return program, which is a brain injury community reentry program. We have 55 ACPIS certified professionals, and that is the most certified professionals of any healthcare system here in Maryland. So we kind of like to tout that a little bit too. As Maria said, I've worked on the neuro unit for about 10 and a half years at this point, almost 11. And I've addressed sexuality and functioning and intimacy here and there, but really began kind of more involved addressing it in about 2018. And I really cringe as to how I probably addressed things as a new grad. And what really sparked this addressing intimacy and sexual function was I had a brain injury patient who I asked her on the day of discharge, you know, what are you going to do when you get home? And she, of course, said, I want to have sex. And I thought, oh my God. I thought, okay, well, we need to address this. And that really prompted my first educational handout, which I think I wrote in, you know, record speed that day. Sorry about that. My badge is going off here, my communication device. In the LifeBridge Health system, we have a bunch of different brain injury programs. We have our Recover Coma Emergence program, which is at our Levendale site. Program candidates must be less than 1 year from the onset of their injury and score a minimum of 5 points on our JFK coma recovery scale. On my inpatient rehab unit, the neuro rehab unit, we have what's called our Restore program. This includes an orientation log for each of our patients. We have an agitation log, which talks about, you know, what was the stimulus for the agitation? Was it auditory, tactile, visual? You know, what was the patient's response? And then also, what strategies did we do for reducing that behavior, and were they effective? We have our agitation behavior scale, which is a form that's filled out by nursing, again, noting some agitated behaviors. We also work on room modifications, making it either a white room, you know, decreasing distractions depending on their Rancho level. And we also have what's called behavior rounds, which is run by our rehab psychologist. Within our system, we also have the Return program, which is an intensive neurorehabilitation day program, and that serves adults who have sustained a brain injury. And they have sessions from around 10 a.m. to 3 p.m. each day with group sessions as well as individual sessions. And then LifeBridge Health also has our mild brain injury program, which is designed to rehabilitate those individuals who have sustained a recent brain injury, or to work with those who have long-standing brain injury-related symptoms as well. And we also offer neuropsych services for our Return program and the mild brain injury program. Some common misconceptions regarding sex and intimacy. People often think that it's a taboo topic and that we should never address it in the hospital setting. They might think that sex is the last thing on a patient's mind following a brain injury, and that people with disabilities have no interest in sex, or sex is for young people, and that disabled adults are no longer interested in sex and can no longer engage in sexual activity. And a lot of people just think, well, people with disabilities are obviously asexual, right? Some barriers that we've run into with addressing this with our patients. Healthcare professionals' comfort levels. You know, a lot of people are still under the mindset that sex is something that happens in the bedroom. You know, I can't be expected to talk about with this patient, right? A lot of people think it's invasive to the client in their recovery. They think, well, this person just had a TBI. They shouldn't be really interested in sex at this point. They've got bigger fish to fry. You know, or a lack of knowledge and education. A lot of comments that I get even from my peers said, I didn't go over this in school. You know, how can I be expected to address it with someone? What if I offend them? What if I say something wrong? And then we see a lot of, you know, quote unquote, inappropriate behaviors, you know, behaviors that might express themselves in a sexual nature. They may be a cue that sexual function needs to be addressed with this patient, their family, or their caregivers as well. And a lot of people think, you know, if the patient or caregiver never specifically asks me, I don't need to talk about it, right? Well, we know that's not true. We need to be addressing this no matter what the circumstances or our preconceived notions are. So we're going to talk about a few models for addressing sexual function and engagement and intimacy. There are multiple, but I'm only going to touch base on a few that are listed here. The most important thing to think about is whichever model that you choose to follow with your practice, you just need buy-in from the entire team. And for me personally, that's really been the hardest part, is getting all of our staff members to buy into this and realize the importance of this. So most people might be familiar with the PLICIT model. It's kind of the most well-known, which talks about permission, giving the client permission to discuss the topic, opening that door to them. Limited information, we're talking about giving them just enough information as to not overwhelm the patient. Maybe it's just some general handouts and they can peruse at their own time frame. Specific suggestions is talking about, those specific things that the client might try and integrate in their daily activities, or stuff that they need to think about. We're trying to normalize that behavior. For example, I might say, other people have wanted to know about, ABC, kind of fill in the blanks, and that kind of lets them know that it's a normal conversation to be having too. And then that intensive therapy portion is where we're going to refer out to those other professionals, such as a urologist, gynecologist, an actual certified sex therapist as well. Things that we necessarily don't have the toolbox to address on our inpatient rehab unit. This is the most common model. However, there are some limitations. It's not a very team approach. And if the professional is not comfortable bringing up the topic, it doesn't get addressed. So we can kind of see the negative there as well. The next model that we're going to talk about is called the sex PLICIT model. How clever, they put sex in front of PLICIT. Hatjar is actually an occupational therapist, and that S for sex stands for self, meaning considering your own values, your own beliefs, your comfort with addressing the topic. The E is for environment, considering where you are when you're talking about this. Where I work oftentimes is this busy inpatient rehab gym. I'm not going to be yelling in the corner, have you thought about sex? That's just not the right place to be doing it. It's so finding that right environment, the patient's private room, right? I'm actually sitting in our transition apartment right now. It could be a space to find that offers more privacy for those conversations. And then the X part of that is talking about exchange. You're developing that relationship of trust, building that rapport, kind of prepping them ahead of time, like giving them a heads up, but also respecting their wishes if they don't want to hear the information at that point as well. And then PLICIT is the same as what we talked about on that previous slide. This one is the better model, which I really like this because it talks about starting off by just bringing up the topic, which is so important. It was actually developed for the oncology population, and it's talking about, explaining that you're concerned with quality of life issues, which, as we know, can include sexual function and intimacy. Telling the patients that we're going to find appropriate resources to address their concerns, and letting them know that, the timing might not be appropriate, but acknowledge that they can ask for information at any time, and that we're educating the patients about side effects of their condition, medications, and then recording our assessment interventions, in patients' medical records. The intentional relationship model is really reminiscent of occupational therapy's therapeutic use of self. And what that is, it's essentially being aware of yourself, your verbal language, your body language, which personal information that you choose to share with patients to kind of build that rapport, when you're interacting with your client, and then using your own personality and interpersonal skills in order to build that rapport and ultimately make that client feel at ease, to motivate them, and that they can really trust you. Being able to build that trust, to be able to have these conversations that are more delicate in nature, is a really important step. It's also based on the therapist's knowledge and understanding of that acceptance of their self and the way that you bring that relationship to the client as well. And it's also based on, empathy, ethics, mindfulness, just common respect with each other as well. The sexual rehabilitation framework is a multidisciplinary approach, which I think is wonderful. It specifically addresses issues of the patient, but also the partner as well. And it includes sexual drive, sexual interest, their functioning, but also goes along the lines of fertility, contraception, motor and sensory influences, and also bowel and bladder. And it specifically addresses the needs and role of the partner. And as we know, the partner is oftentimes the one who may need the information more than the client themselves, especially with our brain injury patients. And we have the recognition model, which is mainly recognizing that this service user or the client is a sexual being. Kind of provision of sensitive, permission-giving strategies, exploring the sexual problem and concern. And again, addressing issues that fit within the team's expertise and boundaries, but also referring out when necessary. I'm not going to claim to be an expert on gynecological issues because obviously I'm not. So I know that that's out of my wheelhouse. I need someone who has the expertise and the professional to be able to address that specific issue. The biggest barrier that I have faced is trying to get buy-in from other team members. Most people shy away from this topic altogether or get really flustered when it gets brought up. But a little bit later in the presentation, we'll talk about how each discipline can really play a role, an important role in addressing this topic. So we talk about patient education. Oftentimes with our brain injury patients, this starts with orientation. It also comes along the lines of we have to redirect a lot of behaviors and tailoring education to their cognitive level. We want to meet them where they are. We want to match the education that we're providing with the level that they can understand, not only for the patients, but also their caregivers too. So we think of, what is my spouse's education level? Do I need to simplify things? Or can I get really, really medically in depth with terminology and those types of things as well? It might mean very basic information with normalizing behaviors. With lower level Rancho scores, I end up doing a lot of education with our nursing staff, just about what behaviors they should expect. They often try and stop things that are happening, even though experience kind of shows us that this is normal recovery. And whomever does bathing first with a patient can often be the target of, sexual innuendos, actions, etc. And that person can maybe give other staff members a heads up about, hey, Mr. So-and-so did this in the shower, just be aware of that. He might be kind of doing some of those more sexual behaviors. And these behaviors for us also get logged into the agitation log of our Restore program too. So we're keeping track of those behaviors and trying to decide what interventions are effective with those behaviors as well. When we talk about caregiver education, we're trying to involve that significant other or family member as early as possible in that rehab process. We're talking about, when they get right into the hospital with acute care, when they come to the rehab unit, repetition, repetition, repetition. We probably sound like broken records, but the more we say it, the more times, the more they hear it from multiple different people, maybe it'll sink in. We also try and educate on Rancho levels as soon as possible, and what behaviors they might expect for each level as well. Oftentimes our patients' family members aren't ready to hear the information that you're ready to provide. They're focusing on the basics, will my loved one recover? Will they recognize me? What's life going to look like after the hospital? And we need to give that education multiple times, throughout the course of their hospital stay, both verbal and written. And one strategy that we use on our unit is a patient notebook. So each patient on our unit receives this notebook. It's a 3-ring binder that's labeled patient notebook, where we place all educational handouts. And then this goes home with the patient as well, so that, you know, weeks, months down the road, if they are flipping through this binder, they think, oh, I got this on inpatient rehab. You know, they might see an educational handout that we gave to them, or find, you know, a contact number if they have questions, and give us a call, and we can maybe talk through some things that they maybe weren't ready to receive that information when they were on our unit as well. The rehab center at Sinai operates under a family-centered care approach, meaning there really are not strict visiting hours. Obviously, during COVID, we had some restrictions, but as of mid-June of this year, we kind of went back to our regular visiting hours, and now that might be changing soon, given, unfortunately, the uptick in cases. So we'll probably have to get a little bit creative again with how we're contacting our families. But each therapist has received some extensive training, not only through ACPIS, but also in-service webinars, as to addressing these sexual behaviors and function. The interdisciplinary communication on our unit is so amazing. And we're in constant communication regarding patients' behaviors, how they're doing. But I will admit, though, that most of my colleagues do still come to me when they see this behavior. So comfort levels are definitely something that we're still working on. And I've also created a lot of educational handouts that can talk about, how to address it with the patients. You know, here's a script you can follow, a documentation guide as to, you know, how do I write this up? And also a handout that's specifically for the caregivers of persons who have a brain injury, and what they may be expecting from their loved one regarding behaviors and resuming that sexual function and intimate function. So this slide just highlights those Rancho Los Amigos levels of cognitive function. Again, our inpatient rehab unit only accepts levels 4 and above. So that being said, some, you know, corresponding behaviors that you might see with levels 4, 5, and 6. With level 4, you know, we're performing behaviors with no apparent purpose. So I had a patient who was status post motor vehicle accident. He had a brain injury, and unfortunately, it was not his first brain injury. But he would actually stroke himself through the front of his adult diaper, and he would never keep any other clothes on except for the diaper. And so his wife kept trying to, you know, pull his hand away to stop causing the patient to become agitated. But we had lots of education with the wife regarding, you know, this is normal behavior for recovery. And she was really concerned because she had 2 preteen daughters that were getting ready to come to see dad for the first time. And she didn't want him, you know, stroking himself in front of them. So it kind of opened up an opportunity as to how she could redirect her husband when this was happening. He was someone who, if you put like any type of, you know, sports ball in his hand, he would kind of throw it back and forth. So we talked about using that strategy for her, so that his hands would be, you know, for lack of better words, preoccupied. And we also talked with her about how she may be able to explain the behavior to her daughters as well, in case he did do that. With level 5, they might make sexual comments or actions. We had a patient who was a gunshot wound to the head, and he needed 2-person assist for transfers, bed mobility, and any type of movement, really. And he grabbed, you know, my physical therapist partner's arm, and he started kind of caressing her arm, and he made a comment of, oh, I'm just gonna eat you up like a turkey leg. And we could see that his wife was getting really upset in the room. And, you know, it gives us a chance that we were able to redirect his behavior in the moment, but we also were then able to provide education to his wife regarding what normal behaviors are and what that might look like moving forward for him as he progresses through those different levels, those Rancho levels. And then level 6, we're talking about behaviors that are people that are unaware of their impairments, their disabilities, and safety risks. So we had a patient who was attempting to actually stand, to masturbate in the shower with the water running. So he really wasn't aware of his balance impairments, that safety risk with standing in the water running. So we can offer solutions to that of, oh, you can sit on the shower chair and do that. It also allows us a chance to perform that education. It often brings up the fact too that occupational therapy is often the first discipline, at least on our unit, that really sees some of those behaviors, because you're doing the bathing, you're doing the dressing, people are getting naked while you're doing that bathing. So that's oftentimes where we'll see some of those behaviors, or are the first to see those behaviors as well, and can then kind of give the team a heads up, like, hey, Mr. So-and-so is doing this is what worked, and kind of redirecting that behavior as well. Just going through a little bit of the occupational therapy practice framework. It's kind of highlighting, at least on our system, our healthcare system, why, excuse me, OT is kind of the spearheaders of addressing sexual activity and intimacy in our system. So when we talk about the OT practice framework, we're talking about activities of daily living, activities that are oriented towards taking care of one's own body. We've got sexual activities listed, engaging in that broad possibility for sexual expression. Doesn't always mean intercourse. It could mean hugging, kissing, foreplay, masturbation. And then we also have intimacy listed in our practice framework, that close, personal, familiar, trusting, loving relationship with another person or group, in which you have that shared knowledge and understanding too. Our practice framework also includes personal device care management. It's kind of, I laugh sometimes because grouped into this, we've got hearing aids, but we also have contraceptive and sexual devices. So the whole breadth of everything for us. And then we also talk about intimate partner relationships, engaging in activities to initiate and maintaining a close relationship. This may or may not involve sexual activity, but it could. So when we're looking more in depth at occupational therapy, we're talking about those ADLs, the sexual activity, those personal device care, participation in social activities, energy conservation, positioning, and adaptive sexual devices. We need to make sure that we're utilizing our skill set to make sure that we are kind of looking at the person as a whole, and how do all these things affect their intimate relationships and their sexual function. When we think about a patient's self-esteem and how these things relate to that, and we know that self-esteem relates to how you feel about yourself as a sexual being. We look at non-intercourse activities. What does it even mean to someone for them to be able to take maybe an affected extremity and hold their loved one hand? Or can they give them a hug? That means so much to building that intimate bond with people. And we're not looking specifically at the act of intercourse. A lot of people associate sex with intercourse, and we know that there's so much more to that, and that intimacy part of things as well. And we're also looking at bowel and bladder management. Do you need to get on a bladder, a toileting program where you're emptying your bladder every couple of hours, so that maybe when you do go to engage in that sexual activity, that there's not the concern of maybe having an incontinence issue when you're doing that. So looking at the physical therapy portion of things, we all know that physical therapists work on so many different things with our patients. But the above items, the things listed here on the screen, can specifically relate to engaging in that sexual activity or intimacy. So everything listed kind of relates either directly or indirectly help a patient or a person prepare to reintegrate that sexuality into their lives. Improved mobility, strength, stamina, and range of motion may secondarily also improve body image and body confidence too. An important item that I always kind of remind my colleagues, and when I give in-service and presentations to areas of the hospital, that the home therapists are often kind of the first group of people that are in the patient's home, or outpatient physical therapy is one of the first things that are recommended to someone. So they can be very effective in opening up that conversation and normalizing that sexual health rehabilitation as well. Maybe connecting individuals with resources. Even if a patient makes the smallest comment, whether it's inappropriate or not, it may warrant reaching out to another professional that may be able to address the area that that patient made a joke about. And then maybe referring out to women's health as well. Sometimes my speech language pathologists blush when I bring up the fact of dysphagia, dysarthria, and aphasia, and how it relates to kissing, oral sex, and aspiration and communication too. We think about the act of kissing, there's drooling, there's saliva management issues. Thinking about oral sex, oral motor control, aspiration, endurance. And think about positioning with aspiration. A client that's in a higher position produces a natural chin tuck, or having the bed elevated to 30 degrees with either positioning aids or wedges, if they're going to be in a position for an extended period of time. And we all know that communication, verbal and nonverbal, is so important. But if someone is nonverbal, giving strategies for patients to have clear signs for pain or discomfort. For example, maybe holding a handkerchief and waving it if something doesn't feel right or is not comfortable, or they don't want to continue doing something. And then obviously being able to express our feelings, our wants, our needs. Our speech language pathologists, that's their wheelhouse, right? Communication. And thinking about cognitive or perceptual changes as well, compensatory strategies, memory strategies. Do we need a checklist for the things that you need to prepare for, such as, taking your medication at a certain time, or ensuring that you are using contraception, whether it be taking a pill or doing everything you need to do before you have intercourse, and involving partners in this process too. And social skills training, appropriate displays of affection, getting back into the dating game. We think about pragmatics and what that looks like. And also role playing, there could be dating scenarios, expressing feelings with significant others or spouses, friends, etc. Our therapeutic recreation, how often do you get the answer of, well, what do you like to do for fun? And our brain injury patients are like, oh, sex, yeah. Like, okay, well, if that's what they say, let's have something as a response that we can say back to them that's not going to shut down that conversation, but maybe redirect it, and then offer education to a family member, a caregiver, a spouse, as to what they might expect as they progress through their recovery. Sexual activity is often considered a leisure activity, and we think about how socialization can improve confidence, which can lead to improved self-image and also sexual activity as well. When I talk about, my nursing colleagues, they often obviously are the ones who are administering the medications, which gives a good opportunity to talk to them about the side effects of medications, some of which that can be sexual in nature. Educating the patients and their caregivers on these side effects as well. I write in here, being discreet, right? If you happen to walk in on something happening, don't make a big to-do. As long as that patient is in a safe position, check back later, right? Make sure they're okay, and be discreet. Close the door. Maybe they don't need this right at this moment, or I don't need to talk with them. It can wait 5 minutes, and maybe they'll finish what they're doing. And then we have that quote unquote, inappropriate sexual behaviors. You know, a lot of our staff is so quick to shut something down because it makes them feel uncomfortable. You know, of course, we want to address the behavior and redirect if it's appropriate. However, this may mean that we need to provide more education for the patient or their family regarding these behaviors and why they might be occurring as well. You know, of course, we know that our social workers networks are massive webs, right? They know everyone and everything. They're assisting our family members to cope with potentially sexually inappropriate behaviors. They're providing, you know, educational resources for family members on their loved one's specific diagnosis, and they're connecting them with resources. They're amazing. The breadth of what they can do and who they know never ceases to amaze me. I think I learn something every day from our social workers. We also have our rehab psychologist who is helping patients and family members adjust and cope, assisting individuals to recognize problems as well as areas of strength too, identifying behaviors that could affect our treatment, as well as developing behavior intervention plans, you know, and going over the stages of grief. They oftentimes will meet with partners and caregivers to offer support as well as strategies for that adjustment, you know, for coping, making sure that the caregivers and spouses, you know, whomever the loved ones are really understanding what's going on and have the strategies to deal with it emotionally themselves, not only working with the patient, but making sure that the caregivers and loved ones are feeling supported as well. So our ADL apartment is actually where I'm located right now. We call it our home transition apartment. You know, if you look behind me, you can actually see the bedroom. One thing that our inpatient rehab unit offers is overnight apartment stays. So we do have this apartment that's fully functioning. You know, if I turn to my computer, you'll be able to see our kitchen area, our bathroom, and we do have a protocol that we follow if we deem patients appropriate for an overnight stay before they discharge home. And for our brain injury population, this will often include a partner or a spouse who stays with them. We've also used this space for a husband and wife who wanted some alone time and ensure that they wouldn't be interrupted. So it's a badge access room. So right now I have a do not disturb sign on it. And that usually works for people, but we definitely have used this space to, for lack of better words, allowed, you know, that couple to be intimate with each other. And we're very lucky that we have this space that's available, as well as for, you know, determining if they can go home safely, if their caregiver, spouse, loved one can safely help them as they're going home. And this apartment really allows us to do that very nicely. So when we're looking at our medications, I'm talking about some of those side effects, and I know some of the other presenters touch base on these as well. And we not only have our side effects, but we have our sexual side effects as well, and really knowing what to look out for as a caregiver. We all know that our medications come with warnings of possible side effects, but some, like I said, have those sexual side effects as well. Some medications may cause, you know, decreased arousal, impaired ability to achieve an erection, inability to orgasm. You know, we always recommend that partners be aware of the patient's current medication list, as well as what side effects to look out for. And this does offer us an opportunity to discuss sexual side effects as well, with not only the patient, but the spouse, the loved one, the caregiver, so that, you know, they're just as involved in that care. In the medication side of things, sometimes more so than the patient is, but they're also someone that needs to know all of those side effects as well. We also know that blood pressure medications and some cholesterol medications can cause the inability to maintain an erection, and also those antidepressant meds can cause that decreased sex drive, delayed or absent orgasm, as well as ejaculatory disturbances as well. So just making sure that, as many times as we can, not to beat a dead horse, but just to make sure that we're giving that education often, and they're hearing it from multiple different professionals as well. So not only the doctors, but the nursing staff when they're administering them, but maybe, as a cognitive task, the speech therapist is going to look at their medication list, or the occupational therapist. And this is going to allow us just another way to open the door to talking about these sex and intimate relations with people, and maybe not as direct as, okay, I'm going to walk in your room and we're going to talk about this kind of way. We kind of eased into that conversation a little bit more, which may prompt the patient or the caregiver to have some more questions that we can maybe provide some more educational information to them as well. So when we think about the considerations for the care continuum, we have our acute care team, they're seeing the patients, very shortly after the injury. We want to include information on sexual function and intimacy in the discharge instructions. They're kind of the first people that can open that door of communication, even if they don't think that patient or partner is ready to receive that communication. On inpatient rehab, we can kind of continue that communication, right? We have a longer time frame to maybe build some of that rapport to actually, instead of just walking right in with, here's a handout on getting back to having sex, we can ease into it and maybe feel it out, or, give general little, a quick sentence that says, some patients have questions about this. Have you thought about it? And that can be just that quick little foot in the door type of thing. And it allows us to involve, the partners, the family members a little more freely. They feel more comfortable coming onto our unit for some reason. I guess it's just our welcoming nature. But really getting them involved in every step of the way is so beneficial and helpful, not only for general discharge concerns, but specifically for that resuming sexual function and intimate relations as well. When we talk about, our home therapists who have that direct access to the client's routine, they're in the environment where these things might happen, looking at positioning, looking at safety, making sure they can get on and off that toilet safely, so that they can empty their bladder before they want to do something like this, really getting them into a routine that's going to allow the most successful performance for intimate relations and sexual function as well. And then we talk about our outpatient. I don't want to say it's the last opportunity to address some of those things, but it's one of the end steps where patients are going to be having consistent professionals, and those who are capable of addressing this really talk with them about it. The patient can trial those interventions, and they can report back as to this worked, this didn't work, and it just really takes a lot of buy-in from the therapy staff, because it needs to be brought up with the patient, right? Our favorite patients are the ones who come with this agenda and say, this is what I want to talk about. I know I'm having issues with this. And if that includes resuming sexual function, great. It makes it so much easier on our end. But we also need to remind ourselves that if they don't bring it up, we need to, because we might be the only person that talks with them about it. And if we don't, they may be dealing with something, that could be a quick, easy fix, or it could be something like a medication change that their doctor needs to make. And we will have lost that opportunity to give them that healthy and fulfilling sexual health, if you will. And then we always like to recommend support groups to our patients. There's a local brain injury caregiver support group as well through a local university, Loyola Clinical Centers, and kind of more informal ones that we have here under our umbrella of LifeBridge Health. So we have those support groups that we will have. One of the topics, I've spoken with the group before about general concerns for resuming sexual function, which, like I said, can be a general overview of things, but that might prompt, after the session's over, that patient, that caregiver, maybe seeking out a medical professional and saying, like, someone told me about this. Is this something we could take a look at and how it's affecting my sexual function as well? So looking at outpatient level treatment, at the beginning of the presentation, I talked about our return program at Sinai Hospital. And this is something that's an intensive neurorehabilitation day treatment program. So it's for adults 18 plus who have sustained an acquired brain injury. It could be a stroke, it could be an aneurysm, but also includes our TBI patients. And clients in this program attend sessions daily from around 10 a.m. to 3 p.m., which includes, not only group treatments, but also those individual therapy sessions with PT, OT, and speech language pathology. And usually their stay is a 9-week average when going through our program. I've worked with them a lot on changing their intake forms a little bit to have some more inclusive language, but also for adding questions as to if the individual is experiencing any sexual behaviors, either hypersexual behaviors or hyposexual behaviors. And oftentimes the caregivers are the ones who are assisting with filling out these forms. And so they may have noticed some of those behaviors. And on those intake forms, if that's noted, that really gives our therapists, our clinicians, our, neuropsychologists a heads up as to, this is something that we're going to have to talk about while they're here, and, either addressing it with the client themselves or their caregiver to really make sure that we're supporting them and really looking at that person as a whole as well. I really get called a lot to come down and talk with the patients at an outpatient level for the return program, to see them for those OT sessions that's related to intimacy and sexual function, which I'm so glad that they think of me as a resource. But the goal, is to have each person be comfortable addressing this with a patient, a caregiver, whomever it is, because you want that rapport. It doesn't really, it's hard sometimes for this patient to say, okay, well, this person's totally new to me, and now they're talking to me about, my erection and things like that. So every time I'm asked to go down there, I always send some communication that says, hey, is this something, I'll give you all the resources. If you think you have a better relationship with them, maybe it would be best served coming from that primary therapist, or someone that they've actually met for more than 2 minutes before I, walk in the door and talk about sex with them during that, 60-minute session that they have for OT. And then we talk about dating sites. I have actually contacted some mainstream online dating platforms, just to see if they have any special accommodations for persons with disabilities. However, shocker, nobody got back to me from those main websites. But the next slide that I have actually highlights some dating websites that are actually for persons, they're geared towards people that do have a disability too. And that outpatient level treatment also offers us a chance to get people involved with community supports, support groups, events that happen, state brain injury associations as well. So this is a list, pardon me, of those dating sites that I talked about, being specifically for persons with disabilities. While I didn't get a response from those mainstream online platforms, these do specifically cater to persons with disabilities. One of the neuropsychologists and I were chatting after a presentation that I had given a couple years ago at the Brain Injury Association of Maryland's annual conference a few years ago. And we want to do a presentation about online dating guidelines for persons who do have who are post-traumatic brain injury, because there's such a need. And, let's face it, we were already in an online world, and now with COVID and everything, a lot of these, if you're single, right, and you have a brain injury, it's like, how do I get back into that dating scene? So we thought there's a need for that type of information as well. I just wanted to go over an example of how you might start that conversation with your patient. Many men or women who have had an injury to their brain have concerns or questions about that sexual part of their lives. Have you thought about this at all? Would you like to talk to someone about it? That conversation is such a simple, easy script that really just opens up that door. And if they say, oh yeah, I'm so glad you asked about this. Oh my gosh, well now the door is fully open, right? And I can walk right through with all that information I want to give to them. And if they say, no, that really hasn't come up for me, but their loved one is over in the corner saying like, yeah, like we need it. That gives us an opportunity to know, hey, here's a handout, look it over for me. If you have questions, you can ask. Or a specific one, like I talked about, some specific educational handouts for caregivers. Hey, if you have questions about this, just, knock on our gym door, get your nurse to call me on my, communication device that seems to keep going off. But that's just a way to easily at least knock on the door, right? And try and get your foot in about the importance of talking about kind of resuming that sexual function and intimacy. Some resources that I have listed here are our brain injury associations. Specifically, obviously for me being in Maryland, the Brain Injury Association of Maryland noticed so many events and wonderful things that are coordinated for our brain injury population. We try to keep our patients in our own continuum of care, being able to follow them through the acute care levels, inpatient rehab, outpatient, home therapy. It just gives us a chance to capture everyone, if for some reason they didn't get addressed on inpatient rehab, we still have an opportunity in outpatient to make sure that they're getting this information. And having our outpatient liaisons, they'll give our clients a call at home before, like if they get discharged home before they start their outpatient therapy, just to make sure that things are going well for them, and make sure they're going to be coming back for our outpatient therapy. And then we have some community supports. Locally, we have a few amazing programs. We have our SCALE, which is actually a center for aphasia and life enhancement. And it's a place where it allows persons with aphasia to kind of connect. They offer interactive group activities that are designed to really support and empower members as they re-engage in the community. And they give educational materials, training, support for families, which can also include talking about that intimacy and sexual function. And as the clients hopefully gain more communication skills, they may be able to communicate that need themselves at that point too. And then we have what's called MD-TAP, which is our Maryland Technology Assistance Program, which is available to enhance kind of the lives through technology, and accessing assistive technology for either communication, positioning, all sorts of things that can be a good resource for some of our patients as well. So some advice for our providers: you are allowed to laugh, blush, sweat, be nervous. You don't need to be a quote unquote sexpert to talk about these things. Just really working on being comfortable with the topic, just using the word sex, right? Some people are like, woo, right? They blush at it. And really involving the patient's support team, their partners, their caregivers, their children, whomever it is, making sure that people are getting that education as to what to expect for general recovery, but also what it might look like for behaviors that they might be exhibiting, as well as how we can redirect that and what it might look like moving forward, or if there's any effects that may be more long-term as well. So I don't necessarily dread talking to patients about intimacy and sexual activity. I wouldn't say it's my favorite thing to do, but I've just come to really realize the importance of providing that information for both my patients and their loved ones, their spouses, their caregivers, because we're doing them a disservice if we don't talk to them about it. And again, we want to normalize sex. We want to provide the patient options. We can't make assumptions. Assumptions are like the worst thing ever in this situation. And we really want to consider other factors that impact sexuality and intimate relations as well. We think of those assumptions as, oh, well, my patient's not ready to talk about it. Clearly they have bigger fish to fry here. They just, had an injury in their brain. Shouldn't they be focused on the rehab, right? Well, we can't make that assumption because maybe that's all they've been thinking about the entire time. Will I be able to have sex again? What's this going to look like? Like, how am I going to be able to position myself safely? And then we think about those other factors. They could be having pelvic pain. They could have sexual trauma, cardiac conditions, erectile dysfunction, mental health, as well as, there could be some religious things to keep in mind as well. So have some of my references for you all. And if you're interested when we're finished, I can certainly email those out. And I will leave you with a picture of my family when we were actually able to be at a baseball game. I'm not sure what my daughter thought was really angry at the moment, but she's kind of just mean mugging the camera there. So it must have been a bad call. But I will tell you that the Twins did win that day. So go Twins. If you're from Minnesota, you got me.
Kyla, thank you so much for sharing all that information. I have been, muted, but I chuckled several times, really good way to present it, in a fun is not the right word, but, in a positive way.
Yeah.
Maybe just a few questions for you. And I know probably we'll get some more questions as we go, since we have time to address questions. Do you ever note any gender differences in terms of who's most, willing, to ask questions? I know, from working in brain injury that trauma, hospital stay is skewed more towards males, from even today. Anything, that people need to be aware of there?
Yeah, that's a great question. I always thought like I would always hear the questions from, the young male who is, low 20s. But really the questions come from so many different people. Where Sinai is situated in Baltimore, we have a very wide variety. We have a very, kind of low socioeconomic status area, but we also have a very, we're right in the situation of a very highly educated, this is the Jewish area of Baltimore as well, kind of where we're situated, hence Sinai, obviously. But I really don't find any discrepancies or differences between gender. Again, I've had my own assumptions of people, which I need to put my foot in my mouth sometimes, because you see these people, okay, this 90-year-old lady's not talking about sex, but then she's the first one who asks about it, so really just myself even not putting that assumption on someone and trying to provide the information to everyone, whether they want to take it and read it or not, but just offering it to everyone that's available, and then hopefully opens the door to answering questions and addressing if they have an issue as well.
Great. I'm glad you mentioned COVID and dating sites, because I was thinking, I'm sure social isolation has not been an easy thing, to overcome, particularly in this, area specifically. It occurred to me as you were talking about, having information sort of from start to finish, acute, post-acute, that it might be a good idea for a care coordinator or a case manager who's going to pick up that person when they're back home from the hospital. What are your thoughts on having that person maybe even engage in some of those last, moments, so there's kind of a handoff with this topic in particular?
Yeah.
Or should people come back to the OT for more information?
We kind of, I think it'd be wonderful to have that. Our outpatient liaison does that a little bit. I don't think they focus so much on the actual aspect of addressing sexual function, unfortunately. They try and keep them at least in the system so they don't get dropped through the cracks. I think it'd be an amazing idea to have someone who picked up on it and ran with it. We do encourage that people do bring concerns, questions to the therapy team, or specifically ask ourselves. In our outpatient therapies, like, you've got so many different therapists that are working with the same patient that we're trying to get our therapists to all at least be ears open to something they might hear, if it's a joke, if it's a comment, to know that, hey, maybe we need to address this a little bit better. But we're always trying to capture it and address it in a better way. The biggest thing is buy-in from all the staff. A lot of people still say, I'm just really not comfortable talking about it. We're going to leave it to the expert, which is just not fair to everyone. So,
yeah. I hear you. Every state obviously doesn't have a Kyla. So
it's true.
If someone,
it'd be better if we did, right?
It would. I think it would. Who do you feel like is the best person to go to that, for more information about, being able to talk about this, or, who to refer to?
Yeah, I think that's a great question. I'm obviously biased towards the occupational therapist part of the team, just given our practice act, our scope of practice. I would love to be able to say that each, your primary care physician, you should be able to go to them. But in reality, we know that it's not being addressed as a primary care topic unless the client brings it up themselves. So we're really trying to, at least in our LifeBridge Health, our umbrella healthcare company, is trying to really address it as part of our evaluation forms. If I see something on inpatient rehab, I can give a heads up to outpatient if I know that patient is going, and say, hey, they had questions about this. Can you follow up with this? Can you see if those positioning recommendations that I made are working for them? Can you just brainstorm with them? And that gives us a really good opportunity. But I would say it's hard to advocate for yourself sometimes, especially on the intimate nature of these things. But really having the ability to ask anybody, and hopefully that person can get you associated with someone. But like I said, I'm more biased towards occupational therapy because of our practice act. And I think we are very holistic and offer that whole person, and then referring out to, if we don't know the answer or cannot physically help in that way, the right person to help too.
Okay. I know that, some of the states have the benefit of having a traumatic brain injury model system in their state, and that would be in my state who I would go to automatically. And, it's good to know that, occupational therapy kind of as a discipline, feels comfortable and adept at helping people with that.
Yeah.
So, do you think that it would be pretty easy to have somebody come to do an in-service or to a support group meeting, and have that as a topic?
Yeah, I think it's a wonderful idea. I think of all the support groups, not just only brain injury within our system, have tried to be with them at least once a year. Usually they have the same people that are coming back. So trying to address it as a support group, I think, is a great idea, because if you're in a support group, you mean you're a little bit past that point of, okay, we're kind of in this, we know what we need to be looking at. And especially for caregivers too, caregiver support groups, I think it's an important one. But also patient-specific support groups too. It's been really beneficial just throwing out some general topics to them, general things you might see, and then no matter, I think every single one that I've presented at, someone afterwards always has a specific question at that point. So then I get to either answer it if I can, or, let me talk to you, let me get in touch with your OT, your PT, your whomever, and then being able to address it too. But support groups are wonderful.
Gotcha. Great. That's all the questions that we had posted. I guess, our group may feel the same, about coming to you later and asking questions about a specific situation. Thank you so much again. This has been great. Great information to share, and we appreciate you taking your time to share with us.
You're so welcome. I'm so happy to be able to be a part of it. And again, thank you everyone for your patience.
Absolutely. Well worth the wait. This will wrap things up for today's webinar. We hope that you enjoyed our event today and this series as a whole. We would love to have your feedback on your evaluation. Please join us for other training events, our podcasts, our products, our leading practices academies, and some of the more intensive workshops that we're offering. We're hoping you'll save the date for our annual event, which is just around the corner, our State of the States conference in September, where you'll see some additional CE credits being awarded for participation in that. We're a membership organization. We'd love for you to consider joining, and more information about that is located on our website. Again, thank you. Please contact us if you want further information about upcoming events. Don't forget to complete your evaluations at the end of this webinar, and the CEs are bundled again. So after completing this evaluation, your certificate will be emailed to you. Thank you so much and have a great day.